these pain pathways. For disclosure, I'm the founder of Gulf Pain School and president of the Gulf Pain Society, but it's not going to be affecting my lecture anyway. So, as objective, I'm going to start by some epidemiology and pathophysiology of cancer pain, discuss the cancer pain management algorithm and paradigm, describe the optimal way for treating cancer, this is important, and how we can use the breakthrough medications to help with cancer pain. The prevalence of cancer is very important. You can see that 33 to 50% of patients undergoing cancer treatment will have pain. So the number is high. And when they have treatment for advanced disease, the pain risk for these patients is almost 70%. So it's very high incidence. Cancer pain is mixture of nociceptive pain, where it starts with some damage on the peripheral side. There are some dynamic interactions between the cancer itself, okay, and crosstalk between the cancer and the primary afferent nociceptors. So this is important as nociceptive inflammatory pain. And we have what we call the neuropathic pain, which is a lesion of the somatosensory system, which leads to this neuropathic cancer. There's another point important for cancer is the treatment itself. Treatment itself can lead to pain itself. So it's very important to put this in mind when you treat these patients. Pain is underreported for cancer because of many reasons. One of them is that the patient, they believe that the pain is something normal for cancer, which is nonsense in my opinion. Believe that good patients do not complain about pain, which is not a good idea. That concern that talking about pain may distract physicians from treating the cancer itself. This is another reason for underreporting the pain. Fear of addiction of medications. This is something we always talk about. Bottom line, someone who's in pain, he will never be addicted. This is, we'll see how this myth should be removed. And then concern about the tolerance and side effects will reduce the courage to treat these patients efficiently. And concern that pain can be reason for progression of the disease. So this is and fear of injection is the last reason for that. Under treatment cancer is also responsibility of us as physicians, because we don't do frequent assessment for these patients. We just treat them randomly and we hope that it's going to be effective. Clinicians believe that real pain must be objective with objective testing, which does not exist for pain. We know that there's nothing objective. Pain score itself is very subjective, so we don't have any objective for pain, objective measurements for pain. In some areas we have some sort of opioid limits. We are not treating enough our patients because we don't have availability of these medications. These medications are paramount, they are essential for treatment, so we need to think about it when we have patients with cancer. And the last one is that breakthrough cancer pain is not very famous, it's not very well known, because we don't have enough data for that first, at the beginning. And now, since we started having more data and efficiency of these breakthrough pain and the result for that on the outcome of these patients, then we have to think about it. Management of cancer is based on pillars. We have these pillars that we need to think when we treat pain. Pharmacological treatment, non-pharmacological, and interventions. So today I'm going to focus only on pharmacological pain management to help with these cancer patients getting better outcome. So when we talk about usually the ladder of WHO, so World Health Organization, WHO, we know that there are some sort of ladders. The ladder, the steps for pain management, was described at the beginning for cancer. So those who are using the ladder for acute pain, this is not right, because for acute pain we need to be very aggressive at the beginning. We need to be using the higher and strong medication first, and then reduce, taper down later on. For cancer, it's different. We start low and we go slow to reach the higher level, and the higher level, which is the fourth step, is the interventions. So the WHO ladder of pain was described at the beginning for cancer patients. So step 1, step 2, and step 3. So the fourth step for the pain ladder is for the interventions for cancer. We're having more and more interventions for cancer, and the paradigm for that and the algorithm and the recommendation from different societies are very clear. We need to incorporate the fourth level of interventions for the WHO ladder of pain. Opioids for cancer pain. We have lots of ideas about that, how we manage these strong medications with patients with comorbidities. The problem with cancer patients, they have comorbidities. We need to know how to taper up and down. We need to know how to include these medications without having bad outcome. This is the first thing. So, opioid-based pharmacotherapy is the mainstay for symptomatic treatment of cancer pain. This is something we always emphasize on. Safe for the management of cancer pain. This is evidence-based. We know that. Provide a good balance between efficacy and side effects. That's why I was alluding to comorbidities, because side effects can happen with patients with comorbidities. We need to think and have the balance between these things. Misuse, addiction, and diversion are not relevant concern with patients with cancer pain. And this is a very important message I would like to convey today. A patient with pain will never go for addiction. A patient with cancer is in pain. He deserves, like sort of human right, to have medication, strong medication, or enough strong to help him coping with pain or controlling his pain. This is an important point. Despite this, we have still myths of pain management for cancer. What are these myths? Opioids are associated with addiction pain. I just announced this message, clear message. This is a myth. We should not consider these patients as at risk of having addiction. Tolerance limits the use of opioids in patients with cancer. We know that with progression of cancer disease, we can need more. We are in need to have more medications. So this is a myth. There is no tolerance limits. We need to treat these patients as we can, as high as we can. They need to be very well controlled regarding their pain. Opioids are dangerous because of respiratory depression in patients with cancer. Again, this is not right to treat these patients with moderate, for example, or very weak opioids because of the risk of this. These patients are in need, and they will not be at risk if they are treated well and assessed on a regular basis. So, management of metastatic bones, this is also another big subject. We know that there are guidelines for that. I'm not going to go into details on this. Adjuvants also are important. Can be used with other drugs at any level of WHO level. For example, antidepressants. These patients are depressed, so they need some antidepressant, anticonvulsants, muscle relaxants, and bisphosphonates. So we have some adjuvants to help getting this multimodal approach for these cancer patients. Invasive treatment for cancer, basically interventionist for pain. We know that we can help these patients with some interventions, but the mainstay, as I said, are the treatment with narcotics. Cancer pain treatment in patients, we need to think about the persisting pain and the breakthrough pain. This is a concept that we insist usually on that, because if you treat these patients with a baseline treatment, on round-the-clock treatment, you will never reach the outcome that you would like to, because these patients are not still. These patients are mobilizing, these patients are going for work, these patients are sleeping, these patients are exercising. So in between you can have exacerbation of pain, and you need something to help them. Baseline persistent pain, constant and continuous pain that is experienced by the patient for more than 12 hours per day. So we need to take this into consideration when we treat pain. So, what's the definition of breakthrough pain? It's a transitory exacerbation of pain that occurs on the background of otherwise stable pain in patients receiving chronic opioid therapy. They're living their lives, they do their exercises, they live as normal patients, but they have this pain medication on board. We need to think about how we can manage this pain exacerbation. This is a transient, so we need to be very efficacious on that. Okay? The patient with otherwise stable baseline persistent pain. Over the last 20 years, there has been a growing interest in this phenomenon of breakthrough pain medications, increase the number of pharmacological options and delivery systems that can help our patients. This is how it happens. So you have the baseline of opioid or baseline of pain, and then you have these episodes. These episodes should be blunted, they should be controlled in order to have good outcome. So if you have uncontrolled baseline pain, that means your regular medication, round-the-clock medication, is not appropriate. So for breakthrough pain, transient worsening of pain above the background pain level that lasts a few minutes. So short periods of time is very transient. So we need to really have something which can fit exactly with this episode and help with this pain. So breakthrough pain must be distinguished from uncontrolled background pain for successful treatment. This is another take-home message. Clinical feature for breakthrough cancer pain, time to peak severity is very, very quick, so 3 to 5 minutes. Severe, duration of episode is between 15 to 30 minutes. It can be up to 5 episodes per day and precipitated by an event. This is what I was alluding to. These patients, they have their lives, they work, they exercise, and if they have this, we need to be prepared to have something to catch this. And it's predictable in 60% of cases. So this is an important point, because if it's unpredictable, then medication will not be helping. But this is predictable. Patient should have something in his pocket in order to help with that. He knows. Patients, they know exactly what's going on. And this is something we always emphasize on. Uncontrolled breakthrough cancer pain. So if you increase the dose of the baseline medication, you will not cover the peak of these episodes. This is important. Increasing, and if you increase, you have high systemic exposure of risk of side effects. This is important. So the right way to do is not to think about this baseline. You need to think of these peaks that needs to be controlled. And if you don't have enough episodes for breakthrough pain and medications in here, you will have to have and use not the appropriate medication. You'll have slow onset of these analgesics, and they will not catch exactly the episode, the severe pain at that time. So what we do, we usually try to mimic this episode with medication that is fast, efficacious, that can blunt completely the episode of breakthrough pain. So we need to be as efficacious as in here, I'll show it to you. If you have rapid onset of medication but not enough, you will have accumulation of the effect and accumulation of the side effects. So the idea is really to mimic exactly what's going on. And to mimic this, we need a strong medication that is lipophilic, not hydrophilic. So the onset time will be high, and the decrement of medication as pharmacodynamic effect is very, very quick. So we need to really think about this. If you use morphine, which is the usual one that is used, it's useless because it needs time to reach the peak, and then it will last for a long time. So it's not the right way. The right thing is to have lipophilic one, like methadone or fentanyl transmucosal, to help with this peak and to mimic exact episodes for breakthrough pain. So hydrophilic opioids such as morphine display poor absorption and slow onset. And this is exactly what we need to do. We need to have exactly a medication that is rapid with rapid onset, which can blunt completely the episode of severe pain. So the onset time should be rapid, okay? Analgesia, the onset of analgesia should be after 15 minutes per dose. The peak, also analgesic effect of 20 minutes. So quick and efficacious. Duration, 15 to 30 minutes for breakthrough cancer pain episode. Typical one. For oral transmucosal fentanyl citrate, the duration can be up to 5 hours. Oral transmucosal administration takes advantage of characteristics of the oral mucosa that facilitates rapid administration, large surface of area, high permeability, high vascularity, so all the elements that helps on the fast onset, and associated with high bioavailability due to avoid the first pass metabolism. So we don't think about the absorption at the gut, because we bypass this by transmucosal effect. Fentanyl sublingual is the way to do it. A quick dissolving sublingual tablet designed to allow for rapid transmucosal delivery of fentanyl citrate, indicated for the management of breakthrough pain in adult patients using opioid therapy for chronic cancer. The component is fentanyl citrate. It's a potent analgesic with high peak, very quick and fast onset. And we need to know when we treat these patients for a long time to know about the ingredients, because sometimes they have some side effects of that. So we need to think about this. Otherwise, patients that are with this medication on board, in addition to around-the-clock medication that helps for the baseline pain, will be in good shape because they are calm. They know that if it happens, they will control it very easily. So nothing to worry about. So this is a summary of it. So I like this shift, this stepwise healthcare interventions for cancer pain. It's based on many approaches. If you have a nociceptive pain, then you have to have a regular assessment. You have steps for that. We know the WHO steps. Mild pain, you have to use paracetamol and NSAIDs, and then you go slow up to the strong opioids. This is for the nociceptive part. If you have a neuropathic component, and this is an important point also, we need to be very good clinician to catch all these signs and symptoms of neuropathic pain. Tingling, burning sensation, pins and needles, hyperalgesia, allodynia, all these things which can happen with patients are in need of specific medication that can help, not only the NSAIDs that we usually see in our patients. So very important. So severe pain, cancer pain, without breakthrough pain medications, it's useless because their quality of life is completely affected. They will not be happy with their medication. So the baseline, of course, we need to have effective communication, listening to our patients. We need to have on board regular assessment. These patients will not be left alone without having regular consultations to help tapering up and down the baseline medication and having on board these medications for breakthrough pain. Always use rescue therapy for breakthrough pain. This is one of the baseline of medications and this recommendation for our cancer patients. So I think I'm done with this overview on the cancer patients, insisting on the breakthrough medications, which needs to be very high in onset time, quick, fast onset time, and having at the same time short duration in order not to have accumulation and side effects. Especially, as I said, these patients are with lots of comorbidities, and they are very, very quickly going towards the side effect part of the medication. Thank you, and enjoy your lunch.